There we go. Well, again, welcome to all who have joined. I'm so pleased that you're here. And is a please excuse the doorbell, but as if people join, that's the sound that we hear. So, and we're so tickled to have so many of you with us today. Again, this presentation is rehospitalization. Can technology prevent this? So what we're going to look at today is what leads us to a rehospitalization or even to a hospitalization. What's happening with our residents that causes that concern? And how does that impact us when a resident is readmitted? There are several ways where that high rehospitalization rate truly has an impact on our facility. And then, of course, the last one is the most important one. And how can we keep our residents in our facility? And how can technology help us to do that? So I know that a majority of you are DONs or perhaps administrators or other nursing home staff. But as a DON, we face so many challenges. We want to provide the best possible care for our residents. And that's really hard when you have so many things pulling at you, when you're trying to keep all these balls in the air, so to speak. We try to hire the most qualified and the most competent staff, and then we train them and train them and do competencies and try to make sure that we have the most appropriate staff working for us. We buy the best equipment that we can within our budget. We do try to access those things, and we know that those things are so important, but not all of us have that ability. Our budgets just don't have the ability. So we do the best we can with what we have.
Excuse me, Cindy?
Yeah.
Did you mean to have it in the notes view for the slides? Your slides are kind of small.
Sorry. I thought I switched it. Hang on. I will switch it back.
Thank you.
Oh,
Thanks.
yes, absolutely. Thank you for sharing that. How's that? Is that better?
Much better. Thank you.
Okay, I'm sorry. Between my main computer and my screen, it sometimes gets confusing. So I apologize, but we're all good to go now, right?
Yes, thank you. That's perfect.
Thank you so much. So, and again, not only do we try to train our people as far as techniques go, or as far as equipment goes, but we also train them in disease states. We're forever coming up with different trainings for the different diseases that we take care of. And we know that our elderly have comorbidities that go on and on and on. So, man, we're really trying to do a lot. We're training our staff. We provide the best equipment. We train on disease states. But there comes a time when we still worry, don't we? We worry that we're missing something. We're worrying that those changing conditions will be caught as soon as they possibly could. And when we do catch them, how long has it been going on? Sometimes that's a really difficult thing to prove or to even just determine. It's so difficult. We think, oh, we'll just go look in the medical record and we'll find, but we don't, do we? We don't find what we're looking for. We don't find the documentation that we thought should be there, that had you or I been out on the floor, we would have documented, but somebody else didn't document it. So does that mean it didn't happen? Or does that mean it just was forgotten to be documented? So when we're thinking about changing condition, which is what preempts, for the most part, people going back to the hospital, we don't know. We don't know when it started. We don't know how long it's been going on. We don't know what those changes, how minute were they, how gradual were they, or how fast were they. We don't have any of that information. But we don't even have sometimes information to prove that they were stable, or that this is what's going on. And this isn't a changing condition because this is how they've been, but it's very difficult if the documentation is missing. So then once again, that question comes up, it rears its ugly head, and it says, what did we miss? Did we miss something? And I don't know about you, but as a DOM, man, that really bothered me. I was worried about that all the time. Is are we keeping up? Are we really managing our residents? And sometimes I felt like, well, maybe we're not. And what do I have to do to improve that? Well, before we can even get into technology, we need to talk about a change in condition. What is that? Obviously, it's a change, as the word implies, the phrase implies, but it's actually a deviation from the resident's clinical baseline. What was their norm? What happens normally on a day-to-day basis? So how do you even know what that baseline is? Well, hopefully, there's documentation for a few days after admission that helps us to determine that. But so when we think about changes in condition, they could include changes from the baseline. Again, got to have that baseline in order to make that decision. Worsening confusion or new altered mental state, new or worsening pain, nausea, vomiting. Of course, any injury would be a change in condition. So when there is a change in condition, a licensed nurse has to conduct a thorough assessment or evaluation of the resident. There's then calling the physician, making sure that physician or the medical director, if the primary care provider can't be reached, of what that change is. And the key here is to have all that information readily available. So again, there's another component for us when we think about teaching our staff. Have we taught them what's necessary to call a physician? I mean, what information is necessary to have available when you're calling a physician? There's a lot of tools out there that can help you with that. But our physicians obviously are going to trust us the more information we have and the more that we've thought it through. Once we've called that physician, of course, then we have to inform the resident and the healthcare representative of what's going on and what the doctor ordered. If he ordered some kind of a treatment or new medications, or if a transfer was indicated to an acute care setting. At this point, that nurse is going to have to enter the new orders into hopefully the electronic medical record, update the care plan. If there's a change, you need to do that. And then, of course, updating the CNA worksheet or assignment or putting it in a book somehow to relay, to communicate the changes that have occurred. This resident should be placed on the 24-hour report so that the next shifts can be watching and following up. Communication to the unit staff, however that might occur in the facility, including in the change of shift report. And of course, informing the RN supervisor. Now, there are times when an RN needs to be called immediately to do the assessment. There are some states that LPNs can't assess. They can do some observations and signs and things like that, but they can't necessarily make any decision about that person. So again, determining where you live is a big factor in what you do next as far as this hierarchy of things to do. These are some of the things that a registered nurse does need to be involved with, and that is if there's a significant change in vital signs, if there's some kind of an injury that you don't know where it came from or how it occurred. If the pain management is ineffective and the resident continues to have pain, medication errors, including overdose. Sometimes, every time before you would transfer somebody to the hospital, you would want an RN to do an assessment to make sure that that was needed. If there's circulatory changes, including the absence of pulses, changes in the respiratory status, if they're congested or have dyspnea, or if their O2 stats change. We talked a little bit about nausea and vomiting. Chest pain is a big one. Identifying if there's a new or a worsening pressure ulcer. Was there an accident? Was there an incident? An RN should be involved with that investigation. Altered mental status. If there's lab values that are critical and abnormal, the RN should be called in. An abnormal X-ray or diagnostic test results. These are all things that you would want an RN involved with, but as you can see, there's a lot of things that could go wrong. And so those change of conditions can take, any one of those could become a change of condition in and of itself, but a lot of times we'll see one or two of those happening. So how do you detect the change of condition, and how important is that? I think the biggest thing I want to point out here is that the frontline caregivers have such a crucial role in making sure that our residents get the best care possible. So those frontline staff are really charged with making sure that they're taking care of the resident, and they're documenting, and they're recognizing those changes. So let me just ask this question, and it's kind of a not really needing you to answer, but have you all trained your CNAs in what to report to you that could involve a change of condition? I know some of you use what is called stop and check, stop and report. But the point being is that have we told them that these different things could result or could be indicative of a change in condition? And I think that's really a huge component of our training. So when that doesn't happen, when that identification isn't made or isn't communicated, obviously our resident then is at really a very big risk of declining. That resident potentially could go very fast in their decline. So that swift recognition, and then not only recognizing it, but managing it, is essential. If we want to maintain quality of care in our buildings, we want to make sure that we're complying with all the regulations. And one of them, not the most important, but one of the important reasons is we don't want to send them back to the hospital. We don't want them to have to go back there. And why don't we want them to go to the hospital? Because, gosh, if they went to the hospital, well, that's less work for us. Not really. And some nurses have that opinion. I've had staff nurses that would say, well, I'd rather write a hospital transfer than to have to take care of them all night long in a sicker condition. And in my mind, that just doesn't even make any sense to think about it in that perspective. But there are people who do. In my mind, preventing them from going back to the hospital is really good for them. One, we know that when residents go back to the hospital, they end up sometimes experiencing some confusion because of the change of atmosphere and environment. We know that we're subjecting them to potential infections that could be gotten at the hospital. They get out of their normal routine so that they're not doing what they used to be doing. If they end up in the hospital, they're not going to all their activities. So there's other changes in their social piece that can be displaced. And so again, it just makes sense to keep them in our facility if there's at all a possible way to do that. And so when we do have a system for identifying and for managing those changes in conditions, you know, the team is going to be able to provide that optimal care for residents and ensure their well-being, and will meet the regulatory expectations. So it's just so critical that we keep them if it's at all possible to keep them in our building. But we have to be able to treat them. First, we have to recognize it, and then we have to be able to treat them. So some of the barriers that we have in recognizing those changes in conditions is probably fairly complex, because again, it requires that we have that specialized knowledge and skills. And we know that as we get new nurses into our buildings, we have to teach them a lot. They don't ready to go to be your #1 employee. That's on us. That's on us to give them that training and that experience and that mentoring, so that they can become those great nurses that we want. So again, when you're thinking about a change in condition, some of the things that you have to think about are, well, who's doing the assessing? You know, is that one of my good nurses assessing them? Or is that one that is brand new? And I might have, you know, to help that person a little bit. Or who's taking the vitals? I know in many homes we have CNAs taking vital. Not a problem. But when a vital is not where it should be, it's at that point that the CNA needs to tell somebody, so that a nurse can go in and take that vital. So again, we have the person involved. How familiar is the nurse or the CNA with the resident? Do they really know if this is a change in their baseline for their mental status or for anything going on with them? How do they know? How do they know if they don't take care of them a lot? And always it's difficult to assess residents with dementia as to any of these things, as far as pain or mental status, that kind of thing. It's much more difficult when they do have that dementia. And again, because we have different perspectives of our residents based on how often we've taken care of them or interacted with them, it's going to cause perhaps some discussion about what that resident's condition really is. So you have a CNA saying, she's like this all the time. And then you're having a new nurse on the floor saying, well, I don't know what she's like. I don't know if this is a change. And so you tend to have then some, not disagreements as much as conflicting opinions. And another barrier to recognizing changes in condition is organizational structure, such as what kind of resources do you have to document and to discuss a resident's condition? What's the hierarchy like between the nursing home professionals that often hinder those discussions and sharing observations? Is there some kind of a gap there where it becomes difficult to take things upward? And lastly, of course, is our staffing ratios. Do we have enough staff to take care of the acuity that we have in our buildings? That one can play a huge role when you're thinking about a barrier. So again, we need to know, what kind of barriers do you have in your building? What are you having to deal with? So when we talk change of condition, these are the physical changes that can take place. These are the vital signs, the walking, the level of weakness, even if somebody's become much more weaker in the past day or so. Again, who's recognizing that? And then the non-physical changes, the demeanor. Yesterday they were happy, and today they're not even talking. Have they had a loss of appetite? Has their speech changed? Are they confused? Are they complaining of pain that is either worse or not new to this resident? So hospitalizations and what causes them, I tried to group this into a succinct list, but I'm sure I've missed some things. But I think one of the top issue is failure to identify post-acute care needs, meaning those changes in condition once they've been in our building following a hospitalization. Have we recognized what that baseline was when they returned or in the first few days, and have we recognized if there's been a change to that status? Sometimes it can happen because a physician isn't very timely with follow-up for post-op or follow-up care. So again, first one falls to us as recognizing the care needs. Second one, physicians and their timeliness. Another one that is probably ranking right up there is falls and injuries. We can't prevent every fall from happening, but we can become more sensitive to the possibilities of those, and that's where technology will come in. Medication errors or lack of accurate medication history. Sometimes when we're doing that reconciliation, we do find that there are issues and that potentially something on that order might cause that readmission. Infections, we've often seen people come to us from the hospital and within a couple of days they have an infection that they probably was an HAI over in the hospital, and we have to send them back for that. And lastly, and I don't know how often this is happening nowadays, but I know this was a huge issue that the hospitals were trying to send the patients out, discharge the residents quicker than they were ready to go based on some monetary payments. So these in my mind are what causes rehospitalizations. And so as we look at those, we need to figure out how can we best avoid those from happening. And so hopefully in the next couple of slides, I can share with you how we can do that. But before we get there, let's talk about some examples of change in condition. We have this first one that had to do with vital signs. And Annie came to the Falls Nursing Home in Georgia on the 11th, on 9/11 of 24. When she was admitted, her vital signs were temp 97.8, pulse 66, respirations 20, blood pressure 134/80, oximeter 98%. Well, then as the days passed over the next few days, her vital signs were taken 4 times a day. And on 9/15, a baseline was established so that we could compare that to any changes or any vital signs that were different. Her vital signs were a bit high on admission day. I think we could expect that from most people. My blood pressure goes up when I even just go to the doctors. So I think that's something that is often there, and especially when you think about the emotional change that her life is going to take, it's huge. So now on 9/25, now this is 10 days after the baseline was established, her vital signs were very abnormal. Her temp was up, everything was up, and her SATs were down. So the RN on duty was called, and she checked her vital signs because they had been done by a CNA. And after finding the same results, she reviewed Annie's medical record. There had been no vital signs recorded since 9/15. The documentation was scarce since then and did not indicate any issues besides needing to go to the bathroom more frequently. When the RN interviewed Annie, she found her very confused and unable to really answer her questions. more so than she was when she first was admitted. But again, when checking the medical record, there were no notes indicating that her cognitive status had fluctuated at all. Well, at this point, the RN called the physician and she relayed the changes that she had found in Annie. The physician then ordered an ambulance and a transfer to the hospital. At the hospital, Annie was found to have sepsis, and it was from the UTI. Our only indication she was had any issues was that one little note that said having to go to the bathroom more frequently. Unfortunately, Annie died that evening. The sepsis just ramped up and they weren't able to save her. That's sad, isn't it? Because when you think about it, we dropped some balls here. We dropped the care that we should have been providing. So when we think about this, what happened? The facility procedure was to take vital signs BID for 10 days following admission, and then daily for another 10 days. The nurse that was caring for Annie on 9/25 was following the process of those daily vital signs and discovered her change in condition. So now a root cause analysis was done. And in that root cause analysis, it was discovered that a new nurse had been responsible for 3 of the days that the vital signs were not taken, and they were short-staffed the rest of the days. When the staff who were responsible for taking those vital signs were questioned as to why they weren't taken, they indicated that they had run out of time and they had made a decision that it was the lesser of 2 evils to skip the vital signs versus other treatments that needed to be done. So we just didn't do them. People didn't go in and do them. People didn't document that they weren't done or why. It was just a blank. So that's the first example. Let's look at a second example. This one's on skin breakdown. Now, George was admitted to the same nursing home on 9/3. He had been in the hospital with a left fractured hip. When his admission assessment was done, he was found to be a little bit diminished in his cognitive status, and he couldn't follow directions very well. It was really obvious that George didn't want to move. He just laid absolutely still. The only time he moved is if the staff repositioned him. Although George didn't tell us why he wasn't moving or why he was so still, he did grimace even when the staff moved him. So a care plan intervention was put into place for George that said, let's move him, let's reposition him every 2 hours and provide him with pain meds. All right, so then we leap forward 17 days. And on 9/20, when the staff were in repositioning George, they found that he had an open area on his right hip area. So they called the RN to assess George's skin. The RN discovered that he had a stage 3 ulcer. When she went to review George's medical record, it was determined that he did not have this open area on admission. And there wasn't any documentation since admission that he had any skin issues of any kind. So nothing on admission. And 17 days later, we find that he has a stage 3 ulcer. Of course, the physician for George was called and obtained an order for transfer to the ER with a possible hospital admission. The physician, I think, at this point in time, had lost confidence in the Falls nursing home. because oftentimes they will give us orders and we'll be able to just take care of that. But I think because we hadn't discovered it and it was at this stage, the doctor just wanted to see it and determine what else to do. When he got to the hospital, they staged it at a stage 4 ulcer that needed debridement and treatment, and they kept him for a few days to do that. So he became admitted. When George was ready to go home, the family decided to admit him to a different nursing home instead of returning him to the Falls nursing home. At this point in time, the family was pursuing legal charges against the facility. So again, what happened? Even though the care plan called for him to be repositioned every 2 hours, there was no documentation that it had been done. There were numerous staff interviewed and they couldn't remember if they had done it or not. But when they looked at the scheduling, they found out that most of the days in question, most of those 17 days, there had been many call-offs of the staff. So the staff were working short. Again, how could we have prevented this? How could we have identified that he wasn't being turned or that staff weren't repositioned? We take it on faith that if it's in the care plan and the staff know about it, that they'll do it. But they don't always tell us when they don't. So the question comes to play then, how can technology help us? So we need to ask ourselves, is there some way that technology can help prevent the human error that is always possible and it always will be possible? What's out there that can help us with that? Well, there's a lot of technologies that can help us to identify changing condition. And when we find those changing conditions, if we find them fast enough, they can help us to prevent rehospitalizations. While at the same time, they provide documentation for us in our electronic records. Some examples, and these are just some minor ones, but I just wanted to throw them out there, is vital sign machines that can provide that documentation where they send the information directly to the medical record. Same thing with some of the scales that we have. Scales can actually send that documentation through Bluetooth and document the weights. But that still takes somebody to go in and do that, right? It still takes somebody to go and take the vitals on the vital machine. Even though the machine will document it, it can't document it if it's not done. So we have found that there's another technology that is available that can actually take those vital signs, can help remind the staff to reposition and sync that information of that vital signs and those repositionings with the electronic record. I found this to be so exciting because I thought, wait a minute, it takes the person out of this. And although some of us are old school, I'm very old school, I always like to do it myself. I always like to have my own ears, hear the vital signs, etc. There are technologies now that do a really good job. So let's look at one that we have here today. It's called the Vios Monitoring System. And I just wanted to kind of expose you all to this simply from a perspective of what's out there. I've witnessed this. It's a great system. It is wireless. It's cleared the FDA monitoring platform. It monitors the EKG, the heart rate, the respiratory rate, your pulse rate, your oxygen saturation, your posture, and blood pressure is currently being reviewed by the FDA to add to this. In addition to having this technology that sends this information to your electronic record, and it does it on every 5-minute basis. It also has remote monitoring services on a 24/7, 365 basis. So when the information gets routed to the charts, it's also at the same moment being routed to this remote technician who is very trained and excellent at determining changes in condition, who then calls back to the nursing home and says, hey, Cindy's had a change in her respiratory rate, or Cindy's had a change in her EKG, can tell you exactly, and you can pull off strips, and the doctor can even see it, as we'll see later. But should this be used on everybody? Absolutely not. That's not the intent. The intent is to use it perhaps on new admissions on that first period of time where you're really getting to know them. Maybe you have a long-term resident who's become really unstable. This would be another client that you would want to use it on. Or somebody's acutely ill. They don't need a hospitalization, but because you're keeping them there, but you really want to track how they're doing more specifically. So let's look at a scenario based on technology. Edna, who was 77, was admitted to a 160-bed facility with the diagnoses of pneumonia, cardiac history, and she had a lot of comorbidities. On admission, the VMS, or the Vios Monitoring System, was attached. It showed she was in sinus tachycardia with a consistent rate about 110 per minute, and she had tachypnea that was 32 to 38 breaths per minute. Overnight, though, she abruptly converted into an unprecipitated supraventricular tachycardia. Sorry, I'm just admitting people. And her heart rate jumped to 100 from 109 or 110 to 176 beats per minute. This was persistent and converted into a new onset of atrial fib with a rapid ventricular response. So think about this. This technology is on Edna because she's a new admission, and she had some heart history. Now, what's going on? Well, VMS, here's what happened with the system. The VMS alarmed for a high heart rate. The remote technician verified the alarm, called the bedside nurse for both the high heart rate and the atrial fib. Okay, so what did the nurse do? At this point, the nurse called the physician group, received an order for a medication to treat the cardiac condition, and the heart rate was reduced. So instead of calling the physician and saying, what do we do? And he says, ship them. She was able to call him and say, hey, here's what's happening to Edna. If you want to look at the heart rate, you have the link to look at it. And so he could actually see the cardiac strip and could make that decision of what that treatment should be. At this point, the resident remained at the nursing home. She didn't have to go to the ER. Her heart rate returned to normal, and she was fine. Whoops, so sorry. There's another one, and this one's about Dale. Dale was a 54-year-old who was admitted to the nursing home, and he had sleep apnea. He had a decubitus ulcer on his sacrum, and he had also many comorbidities. He was on 2.5 liters of oxygen. So this resident was going to physical therapy, and when he returned at approximately 1600, he was placed in a semi-Fowler position. His O2 stats started to trend down to the low 80s, and in the evening, it dropped to a critical level by 2015. So by 8:15. Wow. Okay. So in this period of time, in this 4-hour period of time, his stats started dropping. So the monitor alarmed for a low oxygen level. The remote technician called the bedside nurse and told her what was going on. The nurse then went in to see what was going on with Dale. He had fallen asleep in a supine position, causing a rapid desaturation. The nursing home nurse checked on Dale and found the oxygen flow was not turned on. So whoever had returned him had not turned on the oxygen level or turned on the oxygen tank. Well, she turned it on, of course, and the saturation level went up to 93%. The heart rate declined, and he didn't have to go anywhere. But it was because somebody was watching him for those 4 hours and watching this slow decline that they were able to rapidly bring him back to his baseline. So again, what happened with Dale? We stopped it from him having hypoxia and declining any further. So let's talk about the outcomes of it. So the first one with Edna, would we have caught that increased heart rate given maybe she wasn't going to have vitals that afternoon? What if we had? What would we have done? We'd have called the doctor, possibly shipped her to the hospital, like I said earlier. Would we have had the confidence of the physician? Would he have been confident that we could keep and treat her? What if we hadn't caught it? Would we have lost her? Possibly that might have been the outcome for Edna. Dale, again, would we have caught that his oxygen levels were falling? Now remember, not everybody has like every 4-hour vital signs. Once they get in, they might have daily or twice a day. So what's the opportunity then that we're going to catch these things? And again, these are on people who we really want to watch, who are new or who are critically ill or has that potential. If we went to caught it, we would have lost Dale too. The other thing that is really unique with this monitoring system is the repositioning component. With Dale having a ulcer already on admission, it was very important that he be repositioned, and that the repositioning device is a great piece of this technology, because it can tell us when they were last repositioned. And so again, helping us to keep on those every 2-hour positionings or the frequency that your facility has. So I think that that's one of it's all together plays so well as far as trying to prevent those changes in condition. So as we look at kind of a summary, there's a lot of technologies that can make our work easier and safer and promote better care. And as a DON, we all have the goals of making sure that our residents are safe and happy, that we avoid those rehospitalizations, that we take care of the sicker residents to not only to provide that care to the resident, but it can also increase our reimbursement. And we want to be sure that we can take care of the residents that we have with the staff that we have. And staffing is not going to go away real fast. So if we have those goals, how can we best meet those goals with technology? Well, with Vios, especially as we look at the last two scenarios, some of those outcomes were accomplished. We reduced that acute care, hospitalization, readmission, and possibly some penalties if you want to be truthful about it. We don't want the residents to go back to the hospital, but we always have that possibility. And when we have a high rehospitalization rate, then we do encounter some penalties. I think that it allows us to admit residents who are sicker, who have a higher acuity than maybe what we could have in the past. Again, having the physician be able to see some of that technology at work on a real-time basis is really important. Identifying early signs of clinical deterioration. Again, the earlier we find those changes, the quicker we can treat them and prevent the resident from having to go to the hospital, so that in essence treat in place. We've upped the safety and the satisfaction of our residents and our family, because they know that we're watching them all the time by having that device on. And they love it, that amount of attention is being paid to their resident on a 24/7 basis. So as we look at the earlier scenarios, what could we have done for Edna? I think we could have saved her. I think we would have found those things happening sooner to her, and we could have perhaps intervened quicker. George, I do believe we could have saved him as a resident by not sending him to the hospital. I think if we could have used that repositioning device, we could have known that within a few hours that repositioning wasn't going on, and we could have prevented that pressure ulcer. Plus, we could have prevented him from having so much pain. So as we think about it, and I said this too before, but the residents that we admit these days are sicker than what we've admitted before. We're the new hospital. Our assisted livings are the new nursing homes, and our hospitals are kind of like the triage and the ultra care kind of settings that we have. The nice thing about technology is that residents don't have to be in a special unit on a special floor. They can be anywhere in your building because of the Bluetooth opportunities. As I mentioned earlier in my description, the monitor sends information to the bedside monitor, which is the smaller device as you see on the picture here, and then it at the same time sends it to the technician, and it also goes to a nursing station screen. So there's places to see this very quickly throughout the facility. And again, having that professional on the other line telling the nurse, hey, Dale's in trouble, and getting her in there right away to see him is huge. Because this is a mobile type of device, the residents can walk wherever they want to walk. They can go to therapy, and that's really a great thing when they have a monitor under there in therapy. They can really see how walking or any of the exercises is playing a role in their well-being while they're under therapy. So I think the Vios Monitoring System does the following. One thing, I think it's retention. The staff love it. The family love it. It gives them kind of a calming effect of knowing that the residents are being watched. That it has certified technicians that are well versed in all these changes. There's a routine updates that come into the chart every 5 minutes. You can rewind and you can go back and you can look at cardiac strips if you want to see progression. There are phone numbers set up, so everybody who needs to be notified is notified. The nice thing is that you can put your own standards in. So you can say, this is when we want to be notified, when the pulse goes above such and such. And the same thing, it can be resident specific. If you've got a really kind of dicey situation going on with the resident, you can say, well, our normal is 60 when it goes above 60, but for this resident, when it goes above 50, we want to be notified, that kind of thing. And the monitor sits within 30 feet of the residents. So it's all a really, I think, a great tool. You can see here, this is the actual device. It's very small. It has some leads to it. So if we were using this type of technology, what would change at your facility? Your vital signs would be done and recorded. The posture would be recorded to identify repositioning needs. Your staff could be freed up to pursue activities such as assessing and other documentation needs. And with the real-time information coming in from the remote monitors, you can catch those declines faster. You can ensure that your repositioning is being done, and you can identify if residents are really getting restless in their beds, even with the positioning component of this device. And the nice thing is you don't have to have one for every resident. You can rent or buy a number that is feasible for you. So again, I don't want to get into sales with this, but I just want you to know it's very accommodating for you. The price is fairly low. And when we looked at it, the cost of one rehospitalization could cover the cost of your devices. So I just want to make sure that you are exposed to this technology, because I think that it's one of those that's out there that could be a real addition to your facility. So we all want to meet those goals that we've talked about, keeping our residents safe, stopping the rehospitalizations. And using this device, facilities have actually seen a 40% drop in their rehospitalizations. We're going to take care of sicker residents, which means we'll have a higher reimbursement because they're going to be admitted with higher PDPMs. And things that we thought we could never do before are suddenly right there now that we can actually do that. And I believe that this will help us, that with our shortage of staff, we will be able to take care of those people, even though we don't have all the staff that we need. But some of these pieces will be covered then, so that we can have some comfort in that. So with that, these are the resources that I use for this, and we'll take questions. Are there any questions? Just unmute and ask, and if I can't answer, there's somebody on here who can. So any questions, any thoughts? Anybody see value in this? I'm curious what your thoughts are. Nothing? Nobody's got anything? No questions? Okay. Let me see. There's a couple things in chat. Let me look. Yeah. So somebody corrected me. It's stop and watch, and that I forgot in the blink of an eye. So thank you for that, Sharon. Stop and watch is the CNA component. Thank you. Any other thoughts? Any other questions or anything that anybody would like to share? No? Okay. Well, I don't want to take more minutes of your day than necessary, so I appreciate your attending. Thank you so much. I will send out the PowerPoint handout to all of you who registered and attended. So you do have the internet link here for you for Vios if you're interested. If anybody has any questions after the presentation, please reach out to me and I can connect you with somebody who can help you. Thank you so much. Have a wonderful day.